Hello friends, good evening. I'm Dr. Pankaj Tikku. I'm faculty of pediatrics, and today in this FMGE series, the topic that I have chosen to discuss is a very important topic for your FMGE exams. In fact, we had, I think, if I'm not wrong, at least two questions which were asked last year in December 2021 on this topic. This is a very important topic both for your NEET PG exams and FMG exams right now, because your focus is FMG exam. So we will talk this with regards to the FMG exam. The topic is seizures in children. So seizures are fits in children, and we'll try to discuss all the important things that are relevant from the point of view of seizures or fits in children. First, I would just like to make a few clarifications on some definitions. So I will like to make a few discussion on the definitions of a few topics of seizures, and one topic that I've seen the students asking many times questions on is the difference between a seizure and an epilepsy. Both of these, seizure and epilepsy, are two terms which are often interchangeable terms. Many students, they use the term epilepsy in place of seizure, and sometimes some students use the term seizure in place of an epilepsy. So are they the same terms or are they different terms? See, one of the best way to define a seizure is that it is something which is provoked, which is triggered. And epilepsy usually is unprovoked, untriggered. That means for a seizure, there usually is a triggering factor. For example, that triggering factor can be low calcium. At that time, we call that seizure as a hypocalcemic seizure. Or that triggering factor sometimes can be low glucose. At that time, we call that seizure as a hypoglycemic seizure. Or sometimes the triggering factor can be high fever, when we call it as a febrile seizure. So whenever there is a triggering factor or a risk factor which is present, which leads to the development of a fit, then we call that as a seizure episode. And seizure episodes usually are very transient, short-lasting events. So what is a seizure? Seizure actually is a transient event. It's usually a transient event involving signs and symptoms. It's a transient event involving signs and symptoms, which usually result because of or due to excessive or synchronous neuronal discharges in the brain. So the point that you need to know here is that this is usually a transient event. It's not an event which is known to last for long periods of time. A seizure is a very short lasting event, which usually involves signs and symptoms resulting from excessive or synchronous neuronal discharges in the brain. So these neurons in the brain, they trigger the development of a seizure. And usually that trigger is always present. That can be a low glucose, that can be a low calcium, that can be high fever. There has to be some trigger that leads to a seizure. However, in contrast to a seizure, epilepsy is an enduring predisposition to develop seizures. And usually, in majority of these cases, there is no triggering event present. It's an enduring. Enduring usually means long term. What is meant by enduring? Enduring means long term. Enduring means long term. So it's an enduring predisposition in a child to develop a seizure activity. And usually it is associated with usually it is associated with cognitive, social, and many times psychological consequences. So while a seizure is a very short lasting event, a transient event, an epilepsy is a more long lasting event, an enduring predisposition. Enduring means lasts for long periods of time. An enduring predisposition to develop seizures, usually associated with cognitive, social, and psychological consequences. And the best epidemiological definition, the best way you can identify a seizure, best epidemiological definition by which you can identify an epilepsy is that it is minimum of 2 seizures which have occurred more than 24 hours duration in between them. So 2 or more than 2 seizures have occurred, and there is minimum 24 hours difference. It can be longer than 24 hours also, but minimum 24 hours difference between 2 seizure events. Then we call it as an epilepsy. So minimum of 2 seizures, it can be more also, with a gap of at least 24 hours. It can be a longer gap also, but 24 hours or a longer gap which is occurring between 2 seizure events, then we call it as an epilepsy. So these are the 2 important things that you should remember about a seizure. Seizure is a very transient event, while epilepsy is a long lasting event. Seizure usually does not have any effects on cognition, social or psychological consequences, because it usually lasts for very short periods of time. But that does not mean seizure is not dangerous. If seizures occur again and again, then it can definitely have all these consequences. But a single seizure episode, which is so short lasting, is unlikely to have these long-term consequences. But because epilepsy is known to occur for longer periods of time, it usually is associated with all these effects. Effects on the cognition of the child, effects on the child's social interaction in the community, effect on the child's psychological behavior. And best way to identify an epilepsy is minimum 2 seizures which have occurred more than 24 hours apart. Now, there are a few more definitions that I would like to talk about. One is status epilepticus. In short, a status epilepticus in a child is a continuous seizure activity, or recurrent seizure activity without the child regaining consciousness in between. So it can be identified as either a continuous seizure activity, which is not stopping, or it is a recurrent seizure activity occurring again and again without the child regaining consciousness in between. In the past, status epilepticus was usually defined based upon a time frame, and that time was 30 minutes. So in the past, we used to say an impending status epilepticus is a seizure activity which has lasted for more than 5 minutes, and a status epilepticus is a seizure activity which has lasted continuously for more than 30 minutes. Because usually most of these seizures after 30 minutes used to have long-term effects on the child, neurological events on the child, because of the death of neurons. That is why the term 30 minutes time frame was used to define a status epilepticus, continuous seizure activity for more than 30 minutes. However, recently the definition has been redefined by International League Against Epilepsy, ILAE. So ILAE, or International League Against Epilepsy, has now redefined this definition of status epilepticus, and now they do not use any particular time, say 30 minutes, which is used as the cutoff. In the past it was used, but now they do not use the term 30 minutes, the time 30 minutes, to define the cutoff for saying this is status epilepticus, because according to them, different types of status epilepticus, a generalized status epilepticus, an absent status epilepticus, different types of status epilepticus have different time points after which these seizures will be called as prolonged, or after which they will likely have a effect on the neurological, long-term neurological consequences. So they said we cannot define status epilepticus based upon a single time. So without going into too much of detail for your exams, let me just tell you, they define status epilepticus as a continuous seizure activity which has resulted either because of lack of termination of seizure events. So the mechanisms which are known to terminate the seizure event, either those mechanisms have become defective or are absent. So it's a continuous seizure activity either because of the absence of the termination mechanisms for seizures, or because of initiation of seizure mechanisms which usually lead to prolonged seizures. Important thing is it's a prolonged continuous type of seizure activity occurring, and they have now given two time points, T1 and T2 time points, to define status epilepticus. The T1 time point is usually the time point when the seizure will be considered as a prolonged seizure or a continuous seizure activity. And they say any seizure which lasts beyond T1 time point will be considered as a prolonged and continuous seizure activity, and by T1 the anti-seizure drugs or the anti-convulsive drugs should have been started. T2 time point, on the other hand, is a time point which is considered as the time point for long-term neurological effects or long-term neurological consequences of a status epilepticus. That means any status epilepticus or any seizure activity which lasts beyond T1 time, that seizure will be considered as a prolonged seizure or a continuous seizure, and by this time, T1 time, treatment should be initiated. Any seizure activity, on the other hand, that lasts beyond T2 point is then likely to have long-term neurological consequences because it will lead to usually death of the neurons. And this T1 and T2 time points differ based upon which type of status epilepticus it is. That is why they have not given any one single time point to define a status epilepticus. For example, for a generalized status epilepticus, T1 time point is 5 minutes and T2 time point is 30 minutes. That means a generalized status epilepticus will be considered as a prolonged or a continuous seizure if it lasts beyond 5 minutes, which is the T1 time point. And a generalized status epilepticus will be considered as a status epilepticus which is likely to have long-term neurological consequences if it lasts more than 30 minutes. Why? Because T2 time point is 30 minutes. However, the T1 and T2 time points, which was 5 minutes and 30 minutes for generalized status epilepticus, is not the same for every other type of status epilepticus. For example, if there is an absent status epilepticus, the T1 time point then becomes different. It is 10 to 15 minutes for an absent status epilepticus. For a generalized status epilepticus, it was 5 minutes, but for an absent status epilepticus, T1 time point is different. It is 10 to 15 minutes. That means an absent status epilepticus will be considered prolonged when it lasts for more than 10 to 15 minutes. And the T2 time point for an absent status epilepticus is still not known. Generalized status epilepticus, the T2 time point is 30 minutes, but T2 time point for an absent status epilepticus is still not known. So what you should know is that the definition of status epilepticus according to the International League Against Epilepsy has been redefined, and now we are not giving any particular cutoff duration beyond which a seizure activity will be called as status epilepticus. In short, you should just remember that status epilepticus in children are continuous seizure activities or recurrent seizure activities without the child regaining consciousness in between. These usually have been now redefined based upon two time points: when the seizure becomes more than T1 in duration, then it will be called as a prolonged or continuous seizure activity, and when its total duration crosses T2 time point, then it will be likely to cause long-term neurological consequences. Another term that is used is a refractory status epilepticus. Now, as the term implies, refractory status epilepticus is a continuous seizure activity. It's a continuous seizure activity despite the use of at least two anti-epileptic drugs. Particularly a barbiturate, which is one of them. So it is a continuous seizure activity despite the use of at least two anti-epileptic drugs. You have given a first anti-epileptic drug, the seizure did not stop. You gave a second anti-epileptic drug, the seizure still did not stop. You can call it as a refractory status epilepticus. A continuous seizure activity which lasts despite the use of at least two anti-epileptic drugs. And then there is another definition which is known as a super refractory status epilepticus, which is usually a continuous seizure activity or recurrent seizures within or beyond 24 hours. So the time is 24 hours despite the use of anti-epileptic drugs, including continuous infusions of midazolam and or phenobarbital. A super refractory status epilepticus is one step above or even a refractory status epilepticus. A super refractory status epilepticus is a continuous seizure activity or a recurrent seizure activity which keeps on persisting within or even beyond 24 hours despite the use of anti-epileptic drugs. You have used multiple anti-epileptic drugs, including continuous infusions of midazolam or phenobarbital, which otherwise are likely to have stopped the seizure. But even despite their use, if the seizure is still continuing, then you call it as a super refractory status epilepticus. So these are a few important definitions that you should know: seizure definition, epilepsy definition, status epilepticus definition, refractory status epilepticus definition, and a super refractory status epilepticus definition. Then there are a few more things that you should know regarding epilepsy, and one of them is an epilepsy syndrome in children. Now I have just explained you what is an epilepsy, but what is an epilepsy syndrome? Now epilepsy syndrome are actually epilepsies which involve one or more specific type of seizures, and they always have a well-defined age of onset of the seizures and a well-defined prognosis of the seizures. So rather than only a single seizure, an epilepsy syndrome is a epilepsy involving one or more than one specific type of seizures which occur in children, often associated with a defined age of onset of these seizures. So most of these seizures which come under epilepsy syndrome will occur or will start at a particular age group. For example, a West syndrome will start in infants. A Jan syndrome or juvenile myoclonic epilepsies will start in juvenile age groups. A benign neonatal convulsions will start in the neonatal period. So they usually are convulsions or seizures which actually have a well-defined age of onset and also a defined prognosis. Either prognosis will be good prognosis or the prognosis will be poor prognosis. Sometimes the prognosis is variable, meaning good in some, poor in some. For example, I'm not telling all the types of epilepsy syndromes. There are many types of epilepsy syndromes in children, but one important epilepsy syndrome which usually starts in the neonatal period is a epilepsy syndrome which is called as benign familial neonatal convulsions. Now these benign neonatal seizures or benign neonatal convulsions have an excellent prognosis. I'll talk about these a little later also. These neonatal seizures usually start in the neonatal or very early infant period, and they usually stop also in the very early infant period. So usually they have a very good prognosis. They start also in the early neonatal period or early infant period, and they will stop also, terminate also during the early infant period, usually associated with a very good prognosis. Drugs that can be used for the treatment including levetiracetam, topiramate, and phenobarbital. So these are the drugs that have been used for the treatment of benign familial neonatal convulsions, which usually are associated with very good prognosis. West syndrome, on the other hand, I always teach this in my classes. West syndrome, on the other hand, are usually syndromes which involves infantile epileptic spasms. So this usually involves epileptic spasms which start in the infantile period. They usually start in the early infantile period. So they have an age of onset which is early infancy. Some of these seizures may terminate in the mid-infancy period. Some of these seizures may terminate in the mid-childhood period. Basically, the termination period is variable. Hence, the prognosis is variable. Some of them may carry very poor prognosis. In fact, I would say West syndrome largely carries a poor prognosis. And that is what I teach in my classes also. Largely, West syndrome carries a poor prognosis because their age of termination when the seizure stops is very variable. And the drugs that have been used as first-line drugs are ACTH, vigabatrin, and steroids. And I will talk about West syndrome a little later also. These are also called as infantile spasms. Another neonatal syndromes, another epilepsy syndrome which occurs in the early infant period, usually associated with a very severe prognosis, is a syndrome known as the dravet syndrome. Most of these seizures, they usually start in early infancy. So most of these seizures, they start in early infancy. Hence their age of onset is early infancy. And most of these seizures usually do not terminate. So they usually are very, very severe prognosis associated because they do not usually terminate. These seizures, they start in early infancy period and they do not then terminate. They actually continue, often associated with mortalities. Drugs like clobazam and this drug stiripentol has been used for the treatment or for the control of these seizures. Usually Dravet syndrome are associated with very poor prognosis. It's an epilepsy syndrome typically seen in the infancy period. Another epilepsy syndrome that is seen in the infancy period is a benign myoclonic epilepsies in infants. These also occur in early infancy. So they also start in early infancy. So they also start in the infantile period. And in contrast to dravet syndrome, which usually never terminate, benign myoclonic epilepsy infants usually terminate between 3 to 5 years of age. So when these children are between 3 to 5 years of age, many of these seizures stops. Again, the prognosis of benign myoclonic epilepsies is usually variable. Drugs that have been used for the treatment are levetiracetam, topiramate, and benzodiazepines. So 3 epilepsy syndromes. There are many more which start in the infantile period, first year of life. West syndrome, variable prognosis, variable to I will say poor prognosis. Dravet syndrome, definitely a very severe prognosis. And benign myoclonic epilepsy infants, which usually is associated again with a variable prognosis. Juvenile myoclonic epilepsies are epilepsies which usually start in the juvenile period. For example, a juvenile myoclonic epilepsy usually starts in children between 12 to 18 years of age. Although these seizures usually are known to occur lifelong, but most of these seizures usually have a very good prognosis. So the termination usually does not happen. Most of these seizures usually occur lifelong, starting from about 12 to 18 years of age. But overall, very well controlled on anti-epileptic drugs such as valproate, hence usually associated with a very good prognosis. It is sometimes also referred to as the Jan syndrome. This also I usually teach in my classes, the Jan syndrome. Drugs like valproate, drugs like levetiracetam, and drug like topiramate has been used for the treatment of these seizures. So these are a few of the epilepsy syndromes. As I told you, epilepsy syndromes is not one seizure. It is one or more type of seizures which usually occur starting from a specific age group. They may start in the neonatal period, they may start in the infantile period, they may start in the juvenile period, and they usually have a well-defined prognosis, either a good prognosis or a poor prognosis, or good in some, poor in some, a variable type of a prognosis. Another thing that I would like to talk about, which is a very important thing, is classification of seizures. Now, recently, as I told you, International League Against Epilepsy has redefined epilepsy when I was talking about status epilepticus. International League Against Epilepsy has also redefined the way we used to classify the seizures. So the more acceptable current classification of seizures include seizures which are generalized onset seizures, which, as the name suggests, are seizures which are generalized throughout the body, usually involving all the 4 limbs, or they are focal onset seizures. So now please do not use the term partial seizures. Partial seizures is a term that is no longer being used. We are using now the term focal onset seizures. Seizures which usually are limited to a one limb or more limited rather than generalized are known as focal onset seizures. Then there are another type of seizures which are known as unknown seizures. And there are type of seizures which are known as unclassified seizures. Many times what happens is the mother gives us a history of about a seizure in a child where we are not able, based upon the history, we are not seeing the seizure because the child's seizure right now has stopped. But according to the mother's history, when I try to find out was that seizure a generalized or a focal seizure, I am not able to put that child into any one particular category. Hence, I put that child into an unclassified seizure. And sometimes the history is such where I actually cannot even know whether that was a seizure or not, whether mother is actually giving a correct history of a seizure or not, or it was probably a seizure-like event but not a seizure. Then I put it under an unknown seizure. A generalized seizure definitely is a seizure which has occurred in a generalized manner involving all the 4 limbs. Again, it can be motor seizures, it can be non-motor seizures. Motor seizures naturally involve movement activities of the child. Non-motor usually are typical type of absence seizures. Then motor seizures again can be tonic, clonic, tonic-clonic, myoclonic, atonic. But what is important for you to know is that motor seizures are where there is movement activities, while non-motor seizures typically are seizures where the activities have suddenly stopped, absence seizures. Focal onset seizures again can be motor seizures. They can be non-motor seizures. Then these also involve seizures which are associated. So we are saying focal seizures with impaired awareness. And then focal seizures without impaired awareness. When I say focal seizures with impaired awareness, so that means the focal seizure was associated with unconsciousness after a seizure episode. In the past, we used to call this as a complex partial seizure. Now we do not use the term partial seizures. We use the term focal seizures. So all those seizure activities which are focal and are associated with loss of consciousness after a seizure event, we call them as focal seizures with impaired awareness. In the past, we used to call them as complex partial seizures. And all those seizures which are focal seizures and not associated with loss of consciousness after the seizure event, we call them as focal seizures without impaired awareness. In the past, we used to call them as simple partial seizures. So that typical terms of simple partial and complex partial seizures are now no longer being used. Another type of focal seizures are focal to bilateral tonic-clonic seizures. That means they start as focal seizures but later on become bilateral tonic-clonic seizures. In the past, we used to call them as secondary generalized seizures. But now that term secondary generalized seizures is no longer used. In the past, we used to call them as secondary generalized seizures. That means they are generalized but not generalized from the beginning, primary generalized. No, they start from focal seizures, later on become generalized. So we used to call them as secondary generalized seizures, but now instead of the term secondary generalized seizures, we say focal seizures, which have then converted to bilateral tonic-clonic seizures. So these are the definitions that now, the classification that now have been given for a seizure. Generalized onset seizures, focal onset seizures, unknown seizures where we not know whether this is a seizure or not, and unclassified seizure where we cannot put the child into one particular category of seizures. Generalized seizures, motor, non-motor, focal seizures, motor, non-motor, focal with impaired awareness, focal without impaired awareness, and focal to bilateral tonic-clonic seizures. Then seizures in newborns. Now this is again a very important group, neonatal seizures. These are the seizures which occur in the newborns. And as you must be knowing very well, one of the most common type of newborn seizures are actually seizures which are very, very difficult to identify seizures called as subtle seizures. Subtle seizures is actually a type of seizure which is actually so localized sometimes that you will not be able to identify that seizure. The classical generalized tonic-clonic seizures do not occur in newborns. A subtle seizure, for example, may be in the form of recurrent apnea episodes. It can be just in the form of changes in heart rate. It can be just in the form of blinking of eye movements. It can be just in the form of chewing movements. I mean, these seizures are sometimes so small or so, subtle that they actually are very difficult to identify. A person who is not a pediatrician probably may not be able to identify this was a seizure or not. Just apneic episodes in a child, apnea episodes associated with tachycardia will be indication of a seizure. Similarly, only fluctuations in the heart rate in a newborn can be again an indication of a seizure. Blinking of eye movements, chewing, the child having these type of chewing movements can be indication of a seizure. Other type of seizures that can occur in the newborn are tonic seizures, you have clonic seizures, often you have myoclonic seizures, then you can have spasms also. But usually, as I told you, the most common type of seizures that we normally get in newborns are the subtle type of seizures. So if you are asked in your exams, which is the most common type of neonatal seizures, it is usually the subtle seizures. Very, very difficult to identify. Subtle means very difficult to identify. It's actually a seizure which is not associated with the florid symptoms and signs which we typically associate with the seizure activity. Especially, I have heard of a question that was asked, and hence I am telling you, especially there is a type of a seizure activity which occurs in newborns, usually occurring on day 5. It has been called as benign neonatal convulsions. Benign neonatal convulsions. I discussed about this when I was talking about epilepsy syndromes also. When I was showing you epilepsy syndrome chart, the type of seizures syndrome that I told you start in neonatal period was benign familial neonatal convulsions. These benign neonatal convulsions usually are neonatal seizures which normally occur as any type of neonatal seizure, but most commonly as recurrent apnea episodes, and typically they usually start on day 5. So they typically start on day 5 of life. Hence, sometimes it is also called as the 5th day fits. Why are they called as 5th day fits? Because normally these seizures are known to start from the 5th day of life. They can be associated with a family history of convulsions. That is the time when we call it as benign familial neonatal convulsions. And sometimes they can be associated with no family history. Then we call it as a benign non-familial neonatal convulsions, usually associated with very good prognosis. All the causes of seizures that you will like to investigate in these seizures, benign neonatal convulsions, all causes, you will not be able to find out any triggering cause. That is why these are actually considered as seizures which actually have no identifiable cause many times. A family history can be identified. That is when they will be called as benign familial neonatal convulsions. Otherwise, let us talk about overall causes of neonatal seizures. Overall, the most common cause of neonatal seizures usually is hypoxic ischemic encephalopathy. Hypoxia is overall the most common cause of neonatal convulsions, and these are often the cause of neonatal seizures also occurring in the first 24 hours of life. Most neonatal seizures which occur in the first 24 hours of life are because of hypoxic ischemic encephalopathy. So hypoxic ischemic encephalopathy is not only the overall most common cause of neonatal seizures, it is also the most common cause of neonatal seizures which starts in the first 24 hours of life. Other causes are metabolic abnormalities such as hypoglycemia and hypocalcemia, even hypomagnesemia. All of these can be associated with neonatal seizures. Then electrolyte abnormalities in the newborn can again be an important cause of neonatal seizures. Hemorrhages in the brain, intracranial infections, meningitis. structural abnormalities. And then there is a long list even beyond this. Pyridoxine deficiency. Pyridoxine deficiency. Both pyridoxine deficiency as well as pyridoxine dependence have been associated with the development of neonatal seizures. Often these type of seizures are refractory seizures. They are not very easy to control. Pyridoxine deficiency, pyridoxine dependence. In my classes, I normally tell the best way to identify important causes of neonatal seizures are the 5H. Which are the 5H? Hypoxia, hypoglycemia, hypocalcemia, hypomagnesemia, and hemorrhage in the brain. Although there are many more, but these 5H are the most important causes of neonatal seizures. Hypoxia, hypoglycemia, hypocalcemia, hypomagnesemia, and hemorrhage. And hypoxia overall remains the most common cause of neonatal seizures and also the most common cause of neonatal seizures starting in the first 24 hours of life. The drug of choice for neonatal seizures has always remained phenobarbital. So many experts underline or are confident about this fact that phenobarbital should be treated as the drug of choice for most cases of neonatal seizures. We have used lorazepam also IV, midazolam also IV, sometimes diazepam, not very frequently. Then we have used other drugs like phenytoin also for the treatment of neonatal seizures. But overall, phenobarbital remains the first line drug for the treatment of neonatal seizures. Another important FMGE question, which is the drug of choice for the treatment of neonatal seizures? I think it has been asked also in the past, recent past. The drug of choice for the treatment of neonatal seizures, it is phenobarbital. So since we are talking about the treatment of seizures in children, there have been many drugs, anti-epileptic drugs, first generation anti-epileptic drugs, classically phenytoin, phenobarbital, carbamazepine, then valproate, then the new generation, second generation anti-epileptic drugs. But if you are asked how do you treat a seizure in a child, please remember, be it a seizure or be it a status epilepticus, any child who comes to you with a seizure, the first thing that you need to do is always investigate. And if you are able to find out the cause, then you have to treat that cause. Electrolytes should be found out, glucose should be investigated, calcium should be investigated, magnesium should be investigated, then the child's liver function test, kidney function test. In case toxicology is required, the toxicology should also be done for a seizure activity. In case none of the causes of seizures is identifiable, then the first important drug that can be used for the termination of a seizure is a lorazepam or IV midazolam. Both can be given. Either of them can be given, 0.1 milligrams per kg. And here also 0.1 milligrams per kg. So this should be considered as the first line drug for the treatment of seizures. Barbiturates always have remained the first line treatment of choice for neonatal seizures. And in fact, after giving lorazepam or midazolam, in case you are not able to control a seizure, then you might repeat a second dose after 5 minutes. In case still it is not controlled, then you might like to give IV phenytoin or IV phosphenytoin. Either phenytoin or even phosphenytoin. If still the seizures are not getting controlled, even despite giving phenytoin and phosphenytoin, you might like to go in for IV sodium valproate. After giving sodium valproate, if you are still not able to control, then the next drug that can be used in the sequence is levetiracetam. And if after this also seizure is not getting controlled, the next line drug that can be used is phenobarb. phenobarbital. Suppose after this also the seizures are not getting controlled, the next drug that can be used is IV midazolam in the form of slow infusion. IV midazolam in the form of slow infusion. Normally we use 1 to 15 micrograms per kg per minute infusion after shifting the child to the ICU. If seizures are still continuing and still are not getting controlled, cross means the seizures are not getting controlled even after giving midazolam, then a phenobarbital induced coma. If still the seizures are not getting controlled, then obviously now the drugs that can be given are IV ketamine or oral topiramate. And if still the seizures are not getting controlled, then understandably these seizures are very difficult to control. Then the last thing that you have in hand is either a surgery or vagal nerve stimulation or dietary interventions. So all of these can be done when seizures remain uncontrolled despite every anti-epileptic drug that has been given. So this sequence should always be known to you, because you never know what type of question will be asked. For example, they might ask you a seizure wherein a lorazepam, midazolam and phenytoin have already been given. What is the next line drug that can be given in the child? So start with lorazepam, midazolam. Seizure not getting controlled, you might either like to repeat another dose after 5 minutes, and if seizures are still not getting controlled, then you might like to give phenytoin or fosphenytoin. Still not getting control, sodium valproate. After sodium valproate still not getting control, levetiracetam. Still not getting control, phenobarbital. Still not getting control, midazolam, but now in the form of slow infusion, that too in the ICUs. Still not getting control, phenobarbital induced coma. Still not getting control, IV ketamine or oral topiramate, and still not getting control, then obviously surgical correction of that part of the brain which is leading to that excessive seizure activity, or vagal nerve stimulation, dietary interventions. This is then the only thing that is possible. So please remember for your exams the sequence in which these different anti-epileptic drugs are given, and this is very important again for your exams. Regarding epilepsies in children, now there are certain types of epilepsies such as primary generalized tonic-clonic seizures. In the past they were called as generalized tonic-clonic seizures, but when you have a generalized tonic-clonic seizure which starts from the outset only as a generalized seizure, then it is called as a generalized tonic-clonic seizure. But when the generalized tonic-clonic seizure, as I told you, starts first as a focal seizure and then becomes generalized tonic-clonic, then it is known as a secondary generalized tonic-clonic, generalized tonic-clonic seizures. When you actually see primary generalized tonic-clonic seizures in the past, phenytoin and valproate were given as the frontline drugs. More recently, FDA-approved drugs for primary generalized tonic-clonic seizures are levetiracetam, lamotrigine, and topiramate. TPM is topiramate. For all focal onset seizures, the drug of choice always has remained carbimazepine. So carbimazepine, oxycarbamazepine, then lamotrigine, levetiracetam, and this is some of the frontline drugs that I'm talking about. Beyond this, there are many more frontline drugs, but I'm just talking about some of the frontline or first line drugs that can be used for the treatment of these seizures. Absence seizures, well, this question was asked in your exams in December FMGE 2021 also. Absence seizures are actually seizures absence seizures are actually seizures which typically start in children between 5 to 8 years of age. Most of these seizures, they actually, as I told you, are non-motor seizures. So the child suddenly will become blank. They are not associated with any aura, that means pre-seizure event. No. The child will suddenly have a seizure event lasting for a few seconds. It lasts for a very short period of time, few seconds, then it will stop. And multiple such events can occur throughout the day. Usually there is no post-seizure confusion. As soon as the seizure will stop, the child will suddenly resume his normal activity. So a child who has a sudden interruption of his daily activities, whatever he is doing, suddenly the child has a blank stare. There might be flutter movements of the eyes, but he becomes blank. There is no typical motor activity present. The moment seizure stops, the child resumes his normal activity. No post-seizure confusional state. Preceding events such as aura is also absent, and after the seizure event is also absent. Then these are the seizures which usually can be precipitated. So 3 to 5 minutes of hyperventilation can precipitate an absence seizure. So about 3 to 5 minutes of hyperventilation can precipitate an absence seizure. The typical EEG is 3 Hz spike plus a wave pattern. We call it as a spike and a wave pattern, or a spike and a dome pattern. So this type of a pattern is normally present. In the past, it was called as petit mal epilepsy, but now we call it as absence seizure. So now we do not use the term petit mal epilepsy. Now we use the term absence seizure. So you have a spike and a wave, a spike and a dome pattern. This type of a pattern is typically seen in absence seizures. So these children have seizures starting from between 5 to 8 years of age. Sudden interruption of the activity of the child with resumption of activity without any seizure, without any post-seizure state. 3 to 5 minutes of hyperventilation can precipitate the seizures, and the typical EEG is 3 Hz spike and a wave pattern. So all seizures which are following this are known as typical absence seizures. Typical absence seizures. Then there is another type of seizures which are known as atypical absence seizures. They are absence seizures only. But they usually are not having some of these typical features. For example, an atypical absence seizures is not a pure absence seizure. It may have a myoclonic component and a drop in the head tone. So a drop in the head tone or change in the tone of the head and a myoclonic component may be associated with an absence seizure. Then it becomes a atypical absence seizure. Atypical absence seizures also do not have that classical 3 Hz spike and a wave pattern on EEG. They have a slower 1 to 2 Hz spike and a wave pattern. That is again atypical absence seizures. And atypical absence seizures are more difficult to control compared to typical absence seizures. So atypical absence seizures are absence seizures associated with a myoclonic component or change in the head tone. They often have a slower EEG pattern, 1 to 2 Hz spike and a wave pattern, and they often are more difficult to control compared to the typical absence seizures. The drug of choice for typical absence seizures has always remained ethosuximide, but because of its availability issues in India, it has been very well controlled on valproate. Other than valproate, there are other drugs also which are used, but valproate has been an excellent drug for the control of absence seizures in children, which in the past was also called as a petit mal epilepsy. Infantile spasms I have already discussed when I was talking about epilepsy syndromes. In infants I told about epilepsy syndrome starting in neonate, infants, adolescents, juvenile period. When I talked about epilepsy syndrome starting in infants, I talked about West syndrome. So these typical infantile spasms, which are also called as West syndrome, infantile spasms, which is also called as the West syndrome, these normally, as the name suggests, infantile. So they are known to occur as infantile epileptic spasms. Infantile epileptic spasms starting from infantile period. So in the first year of age, usually these spasms will start. Many of them are associated with developmental regression also. Developmental regression, sometimes psychomotor retardation. And then they are associated with a very characteristic EEG pattern, which is known as hypsarrhythmia. What is that characteristic EEG pattern called? That characteristic EEG pattern is called as a hypsarrhythmia. So any epileptic spasm starting from the infantile period associated with developmental regression or psychomotor retardation, along with a characteristic EEG pattern, which is known as hypsarrhythmia. Hypsarrhythmia usually involves very high voltage, slow background rhythm, which is very chaotic. So it's a chaotic or a disorganized background rhythm. It's a chaotic or a disorganized background rhythm, often associated with multifocal spikes. You can see a chaotic or a disorganized background rhythm. This is a typical EEG pattern seen in infantile spasms. So infantile spasms typically is a triad of infantile epileptic activities along with developmental regression, along with a typical EEG pattern which is known as hypsarrhythmia. As I told you, prognosis I would say is variable to very poor prognosis. Some of these infantile spasms may have a preceding development which is normal. That means suppose that infantile spasm starts at the age of 6 months. So till 6 months, some of these children have a normal development. So we call that type of infantile spasm as cryptogenic or idiopathic type of infantile spasm. Cryptogenic or idiopathic type of infantile spasm. Here the preceding development of the child, when I say preceding development, that means the development before the seizure starts in the child is usually normal. So this obviously is associated with a much better prognosis. But there is another type which is usually called as symptomatic type of infantile spasms, which usually have preceding history of developmental retardation. Here there is a preceding history of developmental retardation. So this obviously is associated with very poor prognosis. There is a history of adverse antenatal events present here. That is why I said some may carry a decent prognosis, others may not carry a decent prognosis. That is why we say infantile spasms often associated with variable prognosis. The drug of choice for infantile spasms is always ACTH. Drug of choice is always ACTH. Injections of ACTH always have remained the drug of choice. 150 units per meter square of injection ACTH, 75 units morning evening we divide, give it for 2 weeks. And after 2 weeks of 150 units per meter square per day of ACTH injections, then after 2 weeks you taper the dose gradually, first making it 30 units per meter square per day for 3 days, then 15 units per meter square per day for 3 days, then 10 units per meter square for 3 days, then 10 units per meter square alternate day for 3 days, and then finally you for 6 days, 30 units per meter square for 3 days, 15 units per meter square for 3 days, 10 units per meter square for 3 days, then 10 units per meter square alternate day for 6 days, and then you stop ACTH injections. Vigabatrin is a very important drug, particularly when infantile spasms are associated with tuberous sclerosis. Then the drug of choice is Vigabatrin. So Vigabatrin is an upcoming drug and an excellent drug which has now emerged for the treatment of infantile spasms. In fact, I would say if ACTH is not one of the choices and they're asking you the drug that can be used effectively for treating infantile spasms, your answer should be Vigabatrin. Steroids have also been used for the treatment, prednisolone, but otherwise the drug of choice overall is always ACTH. Juvenile myoclonic epilepsies, I was discussing about this when I was telling you about epilepsy syndromes, and these usually start in the juvenile period. So juvenile myoclonic epilepsies, sometimes also referred to as the Jan syndrome. It's also referred to as the Jan syndrome. So these are seizure activities which start in the juvenile period. As I told you, the typical age group when they occur is usually 12 to 18 years of age. That's the time when these seizure activities start. They can be associated with myoclonic jerks, typically occurring in the early morning hours. Myoclonic jerks. Often leading to things dropping from the child's hand. So often the objects dropping from the child's hand. Sometimes they can also be associated with tonic-clonic seizure activities in the early morning hours. Or sometimes they can be associated with juvenile absences. That means juvenile absence seizures. So any of these type of seizure episodes can be present as a part of juvenile myoclonic epilepsies. They can occur as myoclonic jerks. Myo means muscles. Clonic means rhythmic movements of the muscles. So typical jerky movements starting in the early morning hours. Most of these seizures occur in the early morning hours and leading to objects dropping from the child's hand. They can also occur as tonic-clonic seizure activities in the morning hours, and sometimes they can act as juvenile absence seizures in these children. They can be precipitated. By either any photic stimuli, or they can sometimes be precipitated even by poor sleep. So any child who has not slept properly at night may be at a risk of juvenile myoclonic epilepsies, particularly if they have a risk of development of these epilepsies. There are genetic mutations which have been associated with these epilepsies, which increase the risk of developing epilepsies. So mutations, particularly a mutation in CACNB4 gene, or a mutation in the GABA receptor gene, they all have been associated with increased risk of development, of juvenile myoclonic epilepsies. The typical EEG pattern of juvenile myoclonic epilepsies is 4 to 6 Hz polyspikes and slow wave discharges. And the drug of choice for juvenile myoclonic epilepsies is valproate. Overall, it carries very good prognosis. Overall, these seizures carry very good prognosis, although these seizures often last lifelong, but they are very well controlled on valproate. Other than valproate, also there are drugs that I told you in the epilepsy syndrome table. But juvenile myoclonic epilepsies, best drugs usually include valproate, which often is used as the frontline drug for the treatment of this syndrome, JAN syndrome. The last epilepsy which I would like to talk here is a Lennox-Gastaut syndrome. I've written here Lennox as LA, but I think it is LE. So Lennox-Gastaut syndrome. Now this again is a syndrome which often is associated with a more poorer prognosis. Lennox-Gastaut syndrome are actually combination of mixed seizures. They are often combination of mixed seizures. Many of these seizures includes atypical absence seizures. Includes atypical absence seizures. Or includes myoclonic seizures. So they often have mixed seizures. Along with this, there is history of developmental retardation and a typical slow wave EEG. This is the characteristic feature of Lennox-Gastaut syndrome. Mixed seizures are there, which includes a combination of different type of seizure activities, including atypical absence seizures. They often are also associated with myoclonic seizures. These children often have associated developmental retardation and slow wave EEG pattern. And usually most of these seizures are very difficult to control. So often these seizures are refractory to treatment. Drugs like valproate, lamotrigine, clobazam, topiramate, CLBs, clobazam, topiramate, they all have been used. But ultimately these seizures often are very poorly controlled on anti-epileptic drugs. What is the name of these seizures? Lennox-Gastaut syndrome, Lennox Gastaut syndrome. So these are some of the seizures that you should be aware of, and what are the drugs of choice for your exams. Lastly, with the final thing that I will like to end today's discussion on seizures in children will be the most common provoked seizures of childhood, which are febrile seizures. Now, fever is a very, very important triggering factor for a seizure, and any seizure that is associated with a high-grade fever in an otherwise neurologically normal child, that means meningitis has been ruled out. So, a seizure activity associated with high-grade fever in an otherwise neurologically normal child will be called as a febrile seizure. It's the most common provoked seizures of childhood. Most of these seizures occur in children between 6 months to 5 years of age. Febrile seizures are of two types. One is simple febrile seizures and the other are complex febrile seizures. Simple febrile seizures usually are generalized seizures in comparison to complex febrile seizures, which usually are more focal type of seizures. As I told you, do not use the term partial now. Simple generalized seizures usually include a single seizure episode in 24 hours of fever onset. That means in 24 hours since the fever started, only single seizure episode will occur, while in complex febrile seizures, there will be multiple seizures that would have occurred within 24 hours of the onset of fever. Then simple febrile seizures usually last for less than 15 minutes, while complex febrile seizures last for more than 15 minutes. So it's very important that whenever a child comes to you with a febrile seizure, you should be able to find out whether this is a simple or a complex febrile seizure. Any febrile seizure which is generalized, single seizure activity in 24 hours of fever onset, or any febrile seizure which is associated with a duration less than 15 minutes will be called as a simple febrile seizures. On the other hand, febrile seizures which are more focal, which are associated with multiple seizure episodes within 24 hours of fever onset and which last for a duration of more than 15 minutes will be called as complex febrile seizure episodes. Now, the reason why we actually divide febrile seizures into simple and complex febrile seizures is because of the risk of epilepsies. Some of these febrile seizures may increase the risk of epilepsies after 5 years of age. Normally, most febrile seizures will stop by 5 years of age. But about 3 to 12% of febrile seizures may progress to epilepsies. Especially complex febrile seizures which have a higher risk. Complex febrile seizures. Then febrile seizures which are associated with developmental delay. And febrile seizures which are associated with a positive family history of epilepsy. These are the febrile seizures which actually may increase the risk of epilepsies later in life. Otherwise, most of the febrile seizures will stop by the age of 5 years. But febrile seizures which are complex, febrile seizures which are associated with a developmental delay, and febrile seizures which are associated with a positive family history of epilepsy may increase the risk of epilepsies later in life. About 3 to 12% of febrile seizures may progress to epilepsies. But as I told you, complex febrile seizures have a higher risk compared to simple febrile seizures. Simple febrile seizures overall, the risk is just about 1% for progression to epilepsies. Around 1%. But complex febrile seizures probably have a slightly higher risk. Another thing that you should know is febrile seizures can be recurrent in nature. About 30 to 50% febrile seizures are recurrent in nature. How much? 30 to 50% of febrile seizures are recurrent in nature. That means if they occur once, they often are known to recur again and again. Regarding investigations, no investigations actually are required usually in febrile seizures unless and until either the child is less than 6 months to 5 years of age, 6 months to 1 year of age. So some people say that if a child is less than 6 months of age and he has come to you with a suspected history of febrile seizure, it's better to admit the child, rule out meningitis, because you might not be able to rule out meningitis based upon examination. Meningeal signs usually are very rare, absent in infants. So a child who is less than 6 months of age, or even some books write less than 1 year of age to be on the safer side, even if you are strongly suspecting a febrile seizure, still you should admit the child, do a lumbar puncture, rule out meningitis, and then you can label the child as a febrile seizure. Similarly, in a child who has not been vaccinated, particularly vaccinated for Haemophilus influenza B and pneumococcal, which are very important causes of meningitis. In these children also, lumbar puncture should be done. Then any child where you suspect meningitis strongly, In all these children, lumbar puncture is usually necessary. Otherwise, for febrile seizures, where you are very strongly suspecting a febrile seizure, routine investigations usually are not required. Now, coming last to the treatment. All febrile seizures should be treated like a seizure first. So, if a child comes to you with a seizure-like event, you have to treat it like a seizure, starting with lorazepam, midazolam. As I told you, lorazepam, midazolam you can choose. So, you can treat this as a seizure event. But now the next point is prophylaxis. Should I give prophylaxis against a febrile seizure? Especially because I have said 30 to 50% febrile seizures can be recurrent in nature. So first thing is, long-term prophylaxis is now not recommended with routine anti-epileptic drugs. Regarding intermittent prophylaxis, which can be given during febrile episodes, intermittent prophylaxis during the febrile episodes, during first 3 days of febrile episodes usually. So approximately first 3 days of the febrile episodes, you might like to put the child on a prophylaxis if the child has frequent seizures. And how do you define frequent febrile seizures? If the child has febrile seizures more than three or more than 3 in the last 6 months, or 4 or more than 4 seizures in the last 1 year, then you might like to put the child on intermittent prophylaxis, either with oral diazepam or oral clobazam or with oral clonazepam. These are the oral anti-epileptic drugs that can be considered for intermittent prophylaxis during a febrile episode. So that means whenever the child has a fever, in the first 3 days of fever, you can put the child on these oral anti-epileptic drugs. So you can put the child on these oral anti-epileptic drugs during the first 3 days of the febrile episode. During the first 3 days of the febrile episode, fever episode, to curtail the risk of a febrile seizure, to stop the risk of a febrile seizure. And that too should be done only if frequent febrile seizures are there, more than 3 or more than 3 in the last 6 months, 4 or more than 4 in the last 1 year. Long-term anti-epileptic prophylaxis is not recommended. And let me also tell you here that the best drug, the best way to prevent a febrile seizure is actually to prevent fever. Which is using paracetamol. I mean, there is no better way to prevent a febrile seizure than to give paracetamol, because if you prevent a high fever, you will prevent a seizure. All these oral anti-epileptic drugs are good during the febrile episodes when the febrile seizures are very, very frequent. But otherwise, the best way to prevent a febrile seizure is to prevent fever using paracetamol. Routine long-term prophylaxis is not recommended with anti-epileptic drugs. Any of these you can choose: oral clobazam or oral diazepam, clobazam or clonazepam. Any of these you can choose during the first 3 days of febrile episodes to give as intermittent prophylaxis when febrile seizures are very frequent, 3 or more than 3 seizures in 6 months, 4 or more than 4 seizures in 1 year. So I think with this I finish up the topic of seizure, I'll just do some questions that were asked. For example, this was asked in December 2021 on the first line drug to control febrile seizure. So when a child comes to you in a seizure like episode, as I told you, the first line drug will be the drug that we normally use to treat seizures. And here obviously the answer will be midazolam. Either lorazepam or midazolam, both can be used because you are terminating a seizure episode. Similarly, another question that was asked was this: child with a history of staring episodes lasting for about 20 seconds and abrupt termination. These short lasting non-motor seizures, as I told you, are absent seizures. And for all absent seizures, the drug of choice always will remain valproate. So if you are able to identify what type of seizure it is, it will be very easy for you to answer what should be the drug of choice for this seizure. Similarly, there is a question which I have prepared in the form of a case. A 2-year-old boy is referred to a pediatric neurologist with a history of microcephaly, small head, and 2 episodes of epileptic spasms 24 hours back. So the child is a 2-year-old boy who's come to you with 2 episodes of typical epileptic spasms 24 hours back. There have been frequent episodes of such epileptic spasms starting from 6 months of age. That means when the child was 6 months of age, he was an infant, these type of epileptic spasms started. He is put on phenytoin, but on phenytoin these are very poorly controlled. Now comes the most important way of knowing what seizure this is. EEG shows bilateral asynchronous high amplitude slow wave interspersed with spikes presenting as a chaotic background rhythm, and when there is a chaotic background rhythm, it usually indicates hypsarrhythmia. And hypsarrhythmia usually means that the child had infantile spasm. So this is the case of an infantile spasm. And for all infantile spasms, the drug of choice would always be ACTH. But since ACTH is not a choice here, I told you Behtareen is an upcoming drug, which is a very useful drug for the treatment of infantile spasms. So again, learn how to identify the seizures, and then you can answer the drug of choice. For example, this last question. A 16-year-old girl came in the neurology clinic accompanied by a mother. She had a 6 months history. So girl's age, she's a juvenile, 16-year-old girl. She has a 6 months history of multiple episodes of generalized seizures mixed with altered consciousness and blank stare episodes where she would momentarily lose contact with the surroundings. So this appears to be an absence type of seizures occurring in the juvenile period. So it appears to be a juvenile absence. Let us further see. She also had multiple shock-like flexion episodes involving the arms that tended to occur in the early morning hours. So this is tending to occur in the early morning hours. So these type of jerky movements, myoclonic jerky movements leading to objects dropping from the hand, spilling of contents from a glass in the early morning. This typically indicates that the child has a juvenile myoclonic epilepsy. And if juvenile myoclonic epilepsy is the seizure that this child is suffering from, then the child should be treated with valproate. So valproate should be the drug of choice in these cases. So again, learn to identify the seizures and you will be able to answer what is the best drug of choice for these cases. So with this, I finish up this topic of seizures in newborns, in children. I hope you have understood the topic and you have been able to understand how you will be diagnosing a seizure in children and how overall you will be writing the drug of choice. They are very easy. They might appear as long questions, but if you are able to identify the typical seizure that the child is having, the drug of choice will be very easy to identify. So Thank you very much. And with this, goodbye.